Thank you for joining us today for part 2 of the Managing Microaggressions, What to Do When It Gets Personal webinar series, sponsored by the American College of Surgeons, Surgeon Wellbeing Program, the Committee on Diversity Issues, the International Relations Committee, and the Women in Surgery Committee. I have the pleasure today to introduce Dr. Wendy Greene. Dr. Greene is an Associate Professor of Surgery at Emory University School of Medicine and is the co-chair for the Emory URIM Affinity Group and the Emory Critical Care Center Diversity, Equity, Inclusion. She's also the director of the Acute and Critical Care Surgery Service and the site director for the Acute Care Surgery Fellowship at Emory University Hospital. Dr. Greene is an experienced researcher with interests in the evaluation of disparities, frailty, and outcome in geriatric trauma, acute care surgery, and critical care, and studied the clinical translational link from research interventions to population-based applications in the area of screening, brief intervention, and referral for treatment, education, and training programs. She received her medical degree from Howard University College of Medicine in Washington, D.C. She completed a general surgery residency at Howard University Hospital, a reconstructive surgery residency at George Washington University, a surgical critical care fellowship at the Washington Hospital Center, and a trauma critical fellowship at Inova Fairfax Hospital. She is an active member of the American College of Surgeons, the National Medical Association, Southeastern Surgical Society, Society of Black Academic Surgeons, Association for Academic Surgery, Society of Critical Care Medicine, Society of University Surgeons, American College of Critical Care Medicine, and the American Association for Surgery of Trauma. Thank you, Dr. Greene, for being with us today and moderating our webinar.
Thank you, Jennifer. And thank you all for joining us today for Managing Microaggressions, What to Do When It Gets Personal, this webinar series. Today's webinar is the second in a two-part series exploring microaggressions and surgeon well-being. Part 1 introduced microaggressions and the cumulative effect they have on surgeon well-being, while introducing the challenges to manage microaggressions. Today, we continue to explore the relationship between microaggressions and surgeon well-being. We are joined by a panel of experts for a discussion on how to manage and cope with microaggressions as a receiver and upstander, and the challenges one faces as an upstander or receiver. We welcome Dr. Asmaa Al-Rashed, Assistant Program Director of the Surgical Foundations Program at the Kuwait Institute for Medical Specialization and Faculty of Medicine at Kuwait University. She is a general and bariatric surgeon and intensivist in critical care and anesthesia at Al-Amiri Hospital in Kuwait. Her research and clinical work focuses on the standardization of the care of patients with obesity and bariatric and metabolic surgery, where she has established and led multiple quality improvement projects. Dr. Al-Rashed is a fierce advocate for empowering women in surgery. She is the founder and chair of the Women's Surgery Committee for the Kuwait Association of Surgeons, and has championed the historical documentation and led many activities in tackling gender equity in surgery in the Gulf and the Middle East. She is a co-founder of the Women's Surgeons of Kuwait Research Network that has encouraged and created research opportunities for many surgeons, physicians, and students. Under her leadership, the WSKRN has spearheaded the production of clinical guidelines during the COVID-19 pandemic and has conducted research, educational, and learning activities. Dr. Rashed is a fellow of the Royal College of Surgeons of Canada and a fellow of the American College of Surgeons. Dr. Rashed will provide us with an overview of microaggressions, types, and effects in relationship to surgeon well-being previously discussed in part 1 of this series, which is available for an on-demand viewing on the ACS website. Welcome, Dr. Rashed.
So thank you so much, Dr. Greene, for this kind introduction. And thank you for the American College of Surgeons for allowing me to be a part of this great panel. Today, I'm going to talk to you about microaggressions. What are they? What's their effects? And how do we recognize them? So this topic is extremely important, not because it touches our lives as surgeons and physicians, but also as humans. I have no conflict of interest. So microaggressions have been there for so many years. Today, as I said, we'll be talking a little bit about the definition of microaggression. We'll talk about some of the scenarios where it occurs and identify some groups at risks, and also outline its impact. And hopefully will give you some view of Kuwait, a new experience with microaggression. So microaggression have started many years ago. However, it was until the 1970s when Dr. Chester Pierce have coined the definition for the first time. And as you can see, he's an African-American psychiatrist who initially described that definition where white society has a mechanism in which it would put down the people of color. So initially, it was intended to be for the African Americans. So it's basically subtle and often automatic. It can be nonverbal actions. And then Dr. Su, who's also another psychiatrist, expanded the definition in 2007, in which it included other groups and persons. So it's a brief and commonplace daily verbal and behavioral and environmental indignities where, whether it's intentional or not intentional, but it communicates a hostile message that is negative for like racial, religious slights and insults, and targets persons or minority groups. It was around that time as well when Clinton administration have identified that racism is actually the most dividing force of the nation. So why this topic is important? It's important because it does not affect just the individual, but affect everybody in, it affects many people in workplace, in the community, and eventually it affects the nation. And it has a negative and detrimental impact. The health disparities literature, if you look at it, had showed that there are increased morbidity and mortality rates that was observed among the racial minority. So that's an ultimate sacrifice that people have to pay for, part of the microaggression. So let's take a moment and talk about the types of microaggressions. So Dr. Su have described 4 types of microaggressions. There's micro-insults, micro-invalidation, micro-assaults, and also the microaggression. We'll talk about each one of them. So often the micro-insults, often unconscious, and it usually target the person's, it's like humiliations, that would target the identity of a person or their heritage, and often it is demeaning, and it might not be intentional as well. So this is when you, for example, would assume that the woman is the nurse or the janitor. Another example would be for people would have, for example, Black physicians will be discouraged from wearing their hair color, or they have a religious affiliation and they would appear in a specific way and so forth. Also, for example, listing physicians with their first names on call schedule, this would be part of or a type of microaggression that is experienced by many. Other things like pathologizing the behavior. So if you would say for someone, why you are so girly, or why are you always angry, in reference to a specific race, or for example, or gender. So these are some of the examples of the micro insults. The second type of microaggression that Dr. Su described is also often unconscious, but in that type of microaggression, it will be more of an exclusion. So what would you do is that you would exclude or negate the feelings and the emotions and the thoughts of the other people. It's like when you would say for somebody, I'm blind for color, I don't see color. Even people who would have a disability of color blindness will be able to actually identify there as colors. So when you disregard somebody's feeling or emotions, this is what is called micro-invalidation. It's also another examples is that if you would invalidate the experience of women or underrepresented minorities, for example, by calling them the oversensitive, and also, for example, that you won't acknowledge or address a comment, for example, in a committee where or a meeting where you're sitting, unless it is spoken by the majority. Third example would be the third type. It would be the micro assaults. So these are what we call like the old-fashioned statements or behavior. This is actually conscious, and you actually want to hurt and harm the victim and the person in front of you. So whether it's verbal or non-verbal. So if you would say, why would they let, for example, women to be surgeons, or underestimate the competency of women, for example. Also, when you would refuse to work with somebody based on their gender or their affiliation, like religious or faith affiliation, etc. Another form of microaggression, which is basically the reflection of the culture and the climate at work place, is what we call the environmental microaggression. So this is clearly transmits the prejudice and the bias at the systematic level. So this is, for example, a very common example of that is the hallways that are all decorated by, for example, surgeons, or if you are in a different workplace, it would be similarly the same concept. This is when you would have different criteria when you want to promote someone, and it will be different if the applicant is, for example, woman or from underrepresented minority. Would have, or underrepresented minorities, for example. So this also results into lack of diversity at the leadership, which will cause further problem and will feed the same concept. So one of the microaggression that's not described by Dr. Su, but I came across it, I was learning more about microaggression, is what's called corporeal microaggression. And it was when Smith Oka used an ethnographic framework to study a group of obstetric patients, and they uncovered this kind of microaggression. And this kind of microaggression, the physician will be imposing their own values and potentially provide a hostile treatment for a patient. So, for example, force single women from specific minority or marginalized group would get sterilization, for example. If we are to talk about more forms of microaggression as well, it can be statements and other things as well, as we mentioned earlier. So, for example, saying that Asians are bad drivers, or if you would say Blacks are excellent in playing basketball, that is also a form of microaggression. And it can be as an action. So let's say you're walking in the street and then you would change and cross somewhere else because a person of color that is walking next to you. So that's actually, whether you realize it or not, that's a form of microaggression. Now, I know the pandemic has changed things, but similarly, some people, they're treated as if they were contaminated. You're like at the cashier and trying to pay something, and people are avoiding to touch you. But prior to the pandemic, this is something will be considered as microaggression. And sometimes if you inaction as well, or somebody who looks that they would need an assistant or they're in distress, and you would avoid to provide that because you would assume that somebody else would do that. And obviously we talked about the blindness of color earlier, but if you are, for example, in a party or something, and then there's this person who's from a different minority or and so on, that person would be excluded or not served. That's also a form of microaggression. And then there's the environmental assault, where you would be naming public parks, for example, after Confederate Civil War leaders. There is a study that was done by the American Psychology Association, and that they found that students of color, 90 days period, would be exposed to over 290 acts of microaggressions. That's pretty a lot, you know. This is like having it 3 times a day. And there's that the regular exposure for racial microaggression can lead to mental harm more than what an overt act of hate. There's also one study that looked at Asian American college students and found that the microaggression was significantly and positively associated with cultural mistrust, as well as lower levels of well-being. So I wonder, with all that in mind, if the terminology is accurate for microaggression, or if it's something that we need to discuss and think about. Some of the challenges that we have when it comes to microaggression is the fact that the implicit bias may be very invisible, that someone would not be able to see. This would result into a part of the challenges that trying to addressing the microaggression. Another part as well is that the accumulative effect of it. So I use this as a part of the analogy when you would say that you death by 1,000 cuts, but also, you know, the hair that broke the camel's back. So the intent does not really equal the impact when it comes to microaggression. I'll be talking to you now quickly about our experience in Kuwait. So the concept is completely new, and we in last August 2020 we wanted to conduct this managing microaggression because due to our local needs, we have been hearing, and like some people are voicing out the action that is microaggression in workplace. So we wanted to look at the residents and find out if there was an issue or not. So I'll be sharing with you some of the data that is not published yet, but I thought it was very relevant and important to highlight. And I will tell you what's the difference, or some of the difference that we would see. So Kuwait is a very small country, and then the residency programs are almost exclusives for the nationals. So let's talk a little bit about quickly what we found when we wanted to assess the knowledge and definition and the experience of the residents and fellows. So there's 801 residents in all programs in Kuwait, and we conducted an online survey, 328 residents over 3 days. Most of them have been from Kuwait, over 72%, and some from the Gulf and the Middle East. Majority have been female, and as I said, that was about 25% of the total residents in Kuwait. Surgical and medical were the most specialties that answered the survey, and 52, half of them have been at the junior level, and 39 at the senior level, and 9% of fellows. So what we found is that 56% were not even aware of the term microaggression, but because they have been provided with a definition of it at the beginning, they actually realize that, you know, they've been subjected to microaggression. So 72% have experienced it, and a lot of them did not know how to deal with the microaggression. Almost 60%. So when we looked at the type of the microaggression, most of it has been verbal, but also invalidation and dismissal, and then followed by acts of discrimination. And they have over 60% said that it has a negative impact on them, and majority was not confident to deal with it. So it is really important to understand, although the programs are almost exclusive for Kuwaitis, Kuwait actually by itself have a total population of about 4.5 million, and 1.5 million is actually Kuwaitis. So Kuwaitis are actually minorities in their own country, which is quite interesting. But when you look at the healthcare worker, most of the staff or attending or people involved in the education are actually Kuwaitis. So we actually need to learn more about microaggression in academia as well as in the nation, and the fact that when there's a power play and a difference in a dynamic of the power, things may actually change. So for us to understand more when we look at the international perspective, we really need to understand that things can be different from different parts of the world. So for example, for you to be respectful for somebody in Kuwait, you would call by first name, as long as you're keeping the credential, that is considered respectful. Whereas if you are, for example, in North America, it's the other way around. You have to be called with your last name, for example. Other things and issues that are sensitive and can be different when you want to, and this is important because when we want to compare our studies and our results in Kuwait to a different culture, different things have to take in place. So for example, in our region, women would keep their last name. It's something that's never changed, where this could be different, for example, in other parts of the world. If you want to address, if it's health related issue, pregnancy in a single woman, without verifying a status, this could be a microaggression. When we want to talk, for example, about groups and risks, underrepresented minority in general would be a group at risk for microaggression. Race, as we spoke about, faith and religion, and also gender. But I just mentioned for you, it depends as well. If you're going to look at the international level, you could have different countries with different power and authority that can play and change the picture when it comes to microaggression. So if we want to talk about perpetrators, like literally anybody and anyone at any time could be in that position. And I would say probably I've been a perpetrator at some point in time, whether I realize it or not. So that is extremely important to understand. So studies looked at who would be that, and then they found that the peers, superiors, and even patient can be perpetrators. And one study actually in particular found that patients are actually more perpetrators than victims, and it was more common in academic hospitals versus private hospitals. However, men and women have been equally the same when it comes to being a perpetrator. So this will bring us to the impact, which is the last part of my talk. And it is really important because we are here to help and support our patient. But microaggression have a negative impact on patient. There are some studies and that looked at that assuming a sexual orientation of a patient, for example, have actually a negative impact in building the rapport or the relationship, and actually resulted in early termination of treatment of patients, and some even led to clinical errors. There's a study that looked at the LGBT patient and found that although 93% of the treating physician will not refuse to treat this community, however, 86% preferred not to, and 54% thought that they felt that competent treating these patients. So we do know that microaggression poses barriers to treatment. It can result in inaccurate treatment and inaccurate diagnosis. And worse, it can result in increased morbidity and mortality in racial and minority groups. Now, if we want to look at mental and physical health, similarly, there are a lot of studies that looked at many aspects of mental and physical health, and microaggression have been negatively impacted the well-being, burnout, post-traumatic stress syndrome, as well as decreased immune system, increased blood pressure, depression and anxiety, alcohol use, and suicidal ideation. So there's a lot of serious issues that can lead to such harm for those who suffer from microaggression. If we want to look at the learning impact, similarly, it has a negative impact on academic performance. In some of the study that they look at boys and girls taking a math exam, and just by telling the girls that the boys are better in math, girls have done worse. Of course, it has an impact when it comes to imposter syndrome, racial battle fatigue, stereotype threats, and imposter phenomena have been all described in the literature when it came to the impact of microaggression. When we want to talk about the career advancement, there are studies that looked at that and found as well that women have less, about 39% discussion when it comes to their career advancement. Mentoring is extremely important, and similarly, 60% of men won't feel comfortable mentoring women. So overall, it has really a negative impact on surgeons. Job satisfactions, females, 91% in one of the studies found a poor job satisfaction for female surgeons. We know some studies looked at referral, patients referral, and OR, meaningful OR experiences as well. That was all negatively affecting the woman surgeon's career. feeling of isolation, mistrust, and so forth, as well as lower pay. And of course, this would lead to increased attrition and decreased retention. So I will leave you with Frances Hasselby when she said that cultures does not change because we desire to change it. Culture changes when the organization is transformed. The culture reflects the reality of people working together every day. And this is very important because there are studies that looked at raising awareness and increasing awareness about the bias, and similarly the microaggression. That would not really result, this will result actually in helplessness. However, when it's linked to tangible actions, then there will be an impact. So we have to look and examine the policies, the systems that leads and results into microaggression to be able to actually change the culture. And hopefully this will help us all to build, improve a long-lasting culture in surgery.
Thank you, Dr. Rashed, for setting the foundation for our discussion today. Next, we welcome Dr. Brian Williams. Dr. Williams is a proud Air Force Academy alum and a professor of trauma and acute care surgery at the University of Chicago. On July 7, 2016, he led the trauma team that treated police officers ambushed by a sniper at a racial justice protest in Dallas, Texas. Dr. Williams graduated with the Academy with honors and a degree in aeronautical engineering. After 6 years on active duty, he followed a different call to serve and enrolled at the University of South Florida, Morrisonide College of Medicine. He completed surgery residency at Brigham and Women's Hospital and fellowship in trauma and surgical critical care at Greene Memorial Hospital. As a trauma surgeon, speaker, and author, Dr. Williams dedicates his time working to end gun violence and advance healthcare justice. Today, Dr. Williams joins us to discuss the skills needed to manage microaggressions as the receiver and the challenges faced when managing as a receiver. Welcome, Dr. Williams.
Thank you for having me today. I really appreciate this invitation to discuss this timely and actually timeless topic. And to echo some of the points by Dr. Al-Rashed is that this term microaggressions, it still kind of perplexes me. And I agree with her that maybe we need to discuss like what that actually means for us as practitioners of surgery, but also as those that are on the receiving end of that. Still perplexes me like how to respond, how to tell people to respond to racial microaggressions or microaggressions of any sort. But despite the way we've parsed it academically with all the different definitions and sub-definitions of microaggressions, I think the most important thing to remember is that for the individual receiving it, it's the impact that matters. And that impact is individualized, and many times people are remaining silent about it. So for me, I kind of describe microaggressions as anything short of being called a racial slur, because some microaggressions are actually macroaggressions depending on the receiver. And I will say that I've evolved in how I respond to these over the years. I've learned how to manage my response to it, but it has never gone away. You're kind of swimming in this all the time. It's not episodic, it's a constant, as they may say, death by 1,000 cuts. But this is the situation we're in. This is the society we live in, and we want to provide the best training environment for our trainees, but also provide the best care for our patients. And moving forward on this issue is important. Now, as far as medicine and how I've evolved, I guess one of my first experiences with microaggression occurred when I was in medical schools. It was, I think, 1999, the summer 1999. The Matrix was the big movie at the box office that summer. And I was doing rounds with the team. I was a student with residents, fellows, chief, and attending. We went to the room, and then the patient, after a few seconds, looked and said, pointed at me and said, "I don't want him in here." And it's obvious because I was the only Black member on the team. I wasn't the only student. I was not the only male, but I was the only Black person on that team. So to be singled out was embarrassing. It was silently infuriating. But I didn't know how to respond other than to put the patient's needs first, as we are taught in medicine, and I left the room. But it's afterwards that really stuck with me is that there was never any discussion from my team about what had happened. Not from anybody who was in the positions of power or influenced above me. But also, I don't know that if it was brought up, if I would have actually responded truthfully as well. And that's kind of the constant double bind people are in when they're trying to respond to microaggressions. Do you say something? Do you internalize it? And there's always fraught with danger no matter what. If you speak up and you're not in a position of power, what sort of repercussions could that be to your career advancement? If you say nothing, what does that mean to you personally and how that impacts you psychologically, as Dr. Al-Rashed was discussing? So I don't have a prescription about what is the best way to respond, except that I know that it's situational and that it has evolved as I've moved up through my medical career. And I do advise trainees now that no matter what, you should not have to compromise who you are to be accepted in these situations. You should not have to endure these sorts of continued diminishing of who you represent in order to be accepted. And there are individual responsibilities as well as a collective responsibility based for the organizations and systems to make this a more welcoming environment. So for the individual responding to these microaggressions, the advice I give is you need to know who you are and be who you are. And it's not your job to make those around you comfortable. That is easy to say, but the reality is that we are in a hierarchical profession of surgery. We do have obligations to patients. Therefore, to say that that can happen all the time is not practical. So what do we do collectively? That is the answer that I'm continually striving toward. And I'm hoping that today, for our discussions, we can talk about what are potential solutions for us as individuals to cope with microaggressions, but also those of us that may be perpetrators. How do we change the systems around us so that this is an inclusive environment for all, trainees, our colleagues, as well as our patients? And this may be a new concept for many, and I will say that if it's new to you, it is not a reason to flagellate yourself or even dismiss it. I will leave you with a quote from heavyweight champion and pop icon Muhammad Ali, who said that the person who thinks the same at the age of 50 as they did at 20 has wasted 30 years of their life. We are always in evolution. Now's the time to make change for progress for the future. And I look forward to having a robust discussion with the panel at the end of the presentations. Thank you for having me.
Thank you, Dr. Williams. Next, we welcome Dr. Cherisse Berry. Dr. Berry is an Associate Trauma Medical Director and Assistant Professor of Surgery, New York University, Grossman School of Medicine, and Diplomats of the American Board of Surgery. She completed a master's degree in biology at Harvard University and medical degree at the University of Southern California Keck School of Medicine, and general surgery residency at Cedars-Sinai Medical Center in Los Angeles, California. Dr. Berry completed an acute care surgery fellowship and trauma research fellowship at the R. Adams Cowley Shock Trauma Center, University of Maryland. Following her fellowship, she joined the Division of Acute Care Surgery at New York University Grossman School of Medicine. Dr. Berry is double board certified by the American Board of Surgery in General Surgery and Surgical Critical Care. Dr. Berry has a formidable interest in research, diversity, equity, inclusion, and trauma systems. She has 54 peer-reviewed published manuscripts, received the 2021 AAMC Herbert W. Nickens Faculty Fellowship Award, the 2016 Eastern Association for the Surgery of Trauma Research Scholarship, and selected as an NIH Early Career Reviewer. She has served in numerous leadership roles, including Vice Chair of the 2021 Association of Women Surgeons Program Committee, Chair of the Society of Black Academic Surgeons Women in Surgery Committee, Chair of the New York City Regional Trauma Advisory Council Systems Committee, Co-Chair of the New York State Trauma Advisory Committee Systems Subcommittee, and Governor and Manhattan Council of the American College of Surgeons. Dr. Berry is a surgeon scientist committed to ending racial and ethnic health disparities and to close the gap in achieving health equity. Today, Dr. Berry joins us to discuss the skills needed to manage microaggressions as an upstander and the challenges faced when managing as an upstander. Welcome, Dr. Berry.
Thank you, Dr. Greene. I want to first thank American College of Surgeons for the opportunity to be on this phenomenal panel. Thank you again, Dr. Greene, for the invitation. I'm going to be talking about managing the effects of microaggressions as an upstander. And we'll be talking about some skills some of the challenges in managing as an upstander. I have no conflicts of interest. I think it's important to start by defining what an upstander is. And an upstander is someone who takes action when they see an act of intolerance, someone who speaks or acts in support of an individual or cause, intervening on behalf of a person being attacked or bullied, someone who actively works to create an anti-oppressive world. Now, the opposite of an upstander is a passive bystander. So somebody who can witness bias, microaggressions, as we just learned about, including micro assaults, micro insults, and micro invalidations, or overt racism, and remaining silent. I think the quote from Archbishop Desmond Tutu is quite relevant. So if you are neutral in situations of injustice, you have chosen the side of the oppressor. Because remember, silence is complicity. So in the era of George Floyd, there has been a loud cry for allyship. So allyship is an active and consistent practice of using power and privilege to achieve equity and inclusion while holding ourselves accountable to marginalized people's needs. And we want to stress the term active allyship. So in the face of being a witness to bias and microaggressions, it's important that we have the moral courage to intervene and take action in the moment. So as an active ally, we step up, we speak up, we take action. We're not bystanders. So how to respond? So whether you're an observer, you're the target, or the unintentional perpetrator of microaggressions, we often do not know how to respond to them in the moment. Oftentimes we may feel frozen or defensive if we're the target or the perpetrator. So we're going to spend the next few minutes talking about various strategies for being an upstander. And what we see on the slide are various acronyms for these strategies. We'll go through them one by one. So the GRIT, so that's gather, restate, inquire, talk it out, is really a framework for addressing microaggressions in a non-accusatory manner, really with the opportunities for both sides to reflect on the potential effects of statements and actions. So G, right? Gather your thoughts. Pause, don't react with anger. Decide if it's the appropriate time or place to address the perceived microaggression. Restate, so restate the comment or ask the speaker to restate their comment. Allow the person to clarify or realize the potential negative impact of the words or action. Inquire, to really dig deeper and seek clarification. For example, please help me understand what you mean by that statement. Be non-judgmental, address the comment or action rather than making it about the person. Talk it out. Discuss the potential impact on others and your personal perception. So, for example, in my experience, that comment may perpetuate negative stereotypes. So the key points with the GRIT acronym is to separate the person from the comment, avoid personal attacks or you statements. So saying you are a racist is very accusatory. Instead, consider that remark may be perceived as racially insensitive. If you witness a microaggression, do not speak for the affected person. So avoid stating comments such as you are hurting his or her feelings. Instead, consider this is how I perceived the comment. The next strategy is open the front door. So observe, think, feel, desire. So observe, really describe clearly and succinctly what you see happening. Think, so state what you think about it. Then feel, express your feelings about the situation. And finally, desire, assert what you would like to happen. So here's an example. If an underrepresented in medicine minority faculty member is being asked to represent their entire ethnic group, you might say, let's pause for a moment. I noticed that there seems to be an expectation that an individual can speak for an entire group. I think we need to resist that temptation. It's too much to ask of anyone to speak for an entire community. I feel uncomfortable with this request, and I'd like for us to only ask others to speak for themselves. Another example, if you're in a meeting, I noticed that some people are interrupting others while they are speaking. I think we need to actively listen to all of our ideas so that we can learn from one another and maintain norms of respect at our meeting. I feel uncomfortable moving forward with the discussion. Can we please speak one at a time and give others the chance to share their thoughts? Action. Now, Dr. Linda Berry mentioned this acronym in her excellent presentation during the first session. Ask clarifying questions, come from curiosity and not judgment, tell what you observed in a factual manner, impact exploration, so ask for or state the potential impact of such a statement or action on others, own your own thoughts and feelings, and the next steps, request appropriate action be taken. So for clarifying the question, I want to make sure that I understand what you're saying. Were you saying that? Make sure you clarify. Come from curiosity and not judgment. So you can say statements such as, can you tell me what you were hoping to communicate with that comment? Or can you please help me understand what you meant by that? Tell what you observed in a factual manner. I noticed that, and then go on to explain the facts. Impact. What do you think people think when they hear that type of comment? Or what impact do you think that comment could have on XYZ? Own your own thoughts. So when I hear your comment, I think or feel. Or in my experience, that comment can perpetuate negative stereotypes and assumptions about. I would like to think that is not your intent. Finally, next steps. I encourage you to revisit your view on X, or I'd appreciate it if you consider using a different term, because that's inconsistent with our equity and inclusion policy, as an example. XYZ is another strategy. So I feel X when you say Y because of Z. So I feel uncomfortable when I hear comments about Dr. Smith because he is not here to defend himself. And finally, IQEE. So interrupt, question, educate, echo. So interrupt, so excuse me, can I just clarify what I think I heard? Or before we continue, I want to talk about the language you just used. Question, why do you feel that way? What made you say that? Have you considered the implications of your actions and words? Educate, I'd like to share a different perspective. Let me share my personal experiences. Echo, so when someone else speaks up, echo and reinforce. This really encourages others to speak up and amplifies the upstander. It also lets others know that you are not complicit. So say something to the effect of, thank you for saying something, or I agree with that, and let me add. And the final thoughts, you as an active ally are very powerful. Remember, everyone can do something. At this time in our history, it's even more important that we show up for one another as upstanders. Research shows that even a knowing glance can significantly reduce trauma for the person who is targeted. And one of the most important things we can do is to let the person who is targeted know in some way, however big or small, that they are not alone. Because in the end, as Dr. Martin Luther King Jr. said, we will remember not the words of our enemies, but the silence of our friends. Thank you for your time.
Thank you so much, Dr. Berry, for sharing your insights and perspectives on the challenges with managing microaggressions as an upstander. We will now move into our Q&A. And to start us off, we did receive a question earlier regarding how does one address retaliation after reporting microaggressions? This question came with a personal sharing of an experience, and that individual's experience was affronts towards that person and people in their surgery residency training program and on the faculty level. If anyone would like to address the process of once you've had the microaggressions and you have spoken up, you've done what you thought you could do to now document and share with the authorities above that group, where do you go from here? Dr. Berry?
Thank you, Dr. Greene. So I think the Society of Black Academic Surgeons, or SBAS, is really beginning to look into this. It's a longstanding organization that has really provided support to trainees, to faculty in this space. So I think one of the most important things that you can do is to reach out and talk to somebody in authority, talk to somebody more senior, reach out to organizations such as SBAS to let people know what has happened to you so that you can then develop a support system to begin addressing this, because you can't be alone in this, and there are people out there that can help fight the battle with you, such as SBAS.
Wonderful. Any other panelists like to add their insights on this topic?
I think that's a very valid concern. And, anecdotally, you have to understand that if you're having these issues of microaggression, then you do report it, that the institutions, they're not always set up to look out for your best interests, right? People are told to talk to HR and things like that, but understand that in general, let's just be honest, that they many times exist to protect the institution. So it can be difficult and challenging. Like, what are you going to do when you've exhausted all of your options as far as protecting yourself? So that's where it comes in, that leadership really needs to make this a priority. But like upper level, like an active allyship that Dr. Berry was talking about needs to occur from the highest levels to ensure that there will be safe spaces for people to report issues, but also to not even have to report them in the first place. They shouldn't even exist. I think having some sort of outside entity that can provide some assistance is important, because we've seen plenty of examples of large organizations that are not equipped to investigate themselves when issues like this occur. And one individual going up against that is at a disadvantage.
Would you consider, someone had put in the chat about considering the EEOC or getting an attorney? What other recourses do people have in the system? How the system allows for management of retaliation and addressing retaliation?
Well, attorneys are expensive. It's easy to say just get an attorney, but that becomes expensive. And you can think about it. If you're an hourly worker that's reporting this, you may not have the resources to hire an attorney to help you with these issues. So those avenues do exist, but there are still barriers for a lot of people to get that sort of help behind them just due to financial reasons. The EEOC, I know that there is a backlog. What I've heard is a significant backlog in cases that goes back years. But even that may not be the best avenue if you want to report something now. So I don't know what the best answer is. Things exist, but the reality is that just because they're there, that the functionality of those are not always in the best interests to help out an individual who needs help right now.
If I might add to that, I think it also depends on the retaliation, right? Because that could be variable. So I think it's important to put in your mind, what was the impact? Is the person needs help processing their emotion or what they've been through? That would have a different challenge way of helping it if that retaliation affected the person's job or career. So I think as well, just something to put in perspective, retaliation can be variable, and definitely like, for example, if because I do know that, for example, the systems are different than here in Kuwait and other areas. So I think you really need to know what are the policies in your institution, what are your rights, and then also that will be a factor that would play in terms of deciding what course of action you can take.
Yeah, I agree. And I think this really speaks to the importance of having a structural framework for diversity, equity, and inclusion at every institution, which starts with potentially having a chief diversity officer, having vice chairs of diversity, equity, inclusion for each and every department, so that you have a mechanism for reporting these types of instances, and you have the support to get through it and to kind of fight back. Departments and institutions should have policy of no retaliation, and should have a policy, zero tolerance for this type of behavior. And I think there's really sort of a call to action to strengthen the structural framework for DEI.
Thank you. So I hope for the person who provided those questions that you heard that there's a range of responses based upon the level of retaliation, whether it's an emotional retaliation versus your livelihood. For emotional, sometimes there's faculty support assistance programs within your organization. And for more livelihood concerns, there's the EEOC. And then on a larger structural level, to see that organizations that you may join in the future, you look for those that have organizations that support diversity, equity, inclusion in their HR. So if there's somebody in HR who has a title that is looking out for people. They're not just HR, but they're HR with a diversity bent to them, and that there's some structural things, there's things in place to address your concerns in the future. So we're going to move on to the next question, talking about microaggressions in the workplace, particularly in those countries where there are rampant human rights violations, such as treatment of women and indentured international workers. How should those be addressed on the larger scale?
So I think it's really important to work at all levels at the same time. I don't think you should be addressing microaggression separately in workplace, for example, and not, for example, on the society. So I think it's important to understand the policies, the practices, the legislation, because that can be a part of the systemic structure change. And at the same time, you could work to empower and educate those who are subjected for microaggressions. So it shouldn't be, it all should work together in the same timeline. I wouldn't choose to wait until the structural changes for the system that would happen and then go focus, for example, or do changes into a workplace, for example, should be all at the same time. And I think any step that moves in that direction will support a bigger and more positive change.
Thank you so much. We're going to move on to the next questions. One is dealing with when your superiors or you've told your boss and they don't respond, where do you go from there? Who on the next level to address these concerns? And if it's the medical student, then there should be the College of Medicine. If it is the residents, it should be the head of the program directors should be looking into those particular areas. But understanding, how do we encourage people who have faced these microaggressions? How do we create safe spaces for them to be able to share their story? Yeah, one of the things that I've been able to do is, before the problems are occurred, especially after or during our George Floyd era, created a communication tool, text thread, that during that period of time and throughout and after, the residents were able to communicate with each other and myself, and we could share encouraging messages to one another, because they had a problem with being felt to be invisible. Like, you're going to work every day, you're dealing with all these microaggressions, and you're still supposed to perform at top notch each and every moment. And because their pain was made to be felt invisible, I tried to create a space not only for them, but also for our African-American women at our institution who were feeling invisible, and now have reached out to the African-American men. And it's not just in surgery, but across the organization, so that there is safe places for people to be able to share and discuss. So I would support that as an initial step.
I also agree that leadership making it a priority that the safe space will exist. At least in our Department of Surgery at the University of Chicago, that is happening. We have had a discussion this morning about some of these very issues when it comes to minority representation in surgery and medicine. But I'm sure these conversations aren't comfortable for everyone. But if it's going to happen, it can't just come from the bottom up. It has to become at least something from the top that says this will happen. Here's a protected space. We're going to have this discussion. Let's everybody move toward that area of discomfort in order to progress forward. So again, I like the term active allyship. I had not heard that before. I've heard allyship, but active allyship, I agree. Active allyship allied with someone in a position of power is even better. And that's how we can make these safe spaces to make some sort of progress on these issues for our trainees and our colleagues.
There is one last question that we're going to address regarding, once you get out into the community and you're practicing physicians, and you get targeted with you may not be in the bubble of an academic structure, but you're out in private practice somewhere, and the same infractions or missteps that occur are brought to the level of losing your privileges at your hospital. but it's not happening for your other colleagues. How do you protect yourself in those very vulnerable environments after you've done all your training and made it what you thought to be a safe space?
Yeah, if I may take that, I think it's very important as we go into practice is that we continue to build our support network, whether that would be having a mentor, because you could still be in practice and have mentors, having your colleagues and your friends who can provide for you good advice and who can actually support you and not even try to reach prior to reaching to that stage. But also when you are in that position, it's important to reach out for whoever you think can help you, including professional society. I always tell the resident and the people who I work with, if you don't ask the question, if you don't look, we'll never know that there's an issue or there's a problem. So I think reaching out is extremely important, probably for surgeons who are like you or people who you would trust and see how they can support you and help you through that.
Thank you so much, Dr. Berry, Dr. Rashed, Dr. Williams, for bringing your expertise to this microaggressions webinar, What to Do When It Gets Personal. We thank you so much for joining this American College of Surgeons presentation.